I am honored today to award this year's Arnold Drapkin Honorary Lectureship Award to our very own Dr. Sakshi Dua. This lectureship is part of our Advancing Idealism in Medicine, or AIM initiative, which was initially founded by our residents many years ago and now has grown to an important program for the entire department. AIM seeks to bring us inspirational role models in the humanistic and idealistic practices of medicine. It is therefore fitting that this lectureship is in the honor of Dr. Arnold Drapkin. Dr. Drapkin was a superb and dedicated internist here at the Mount Sinai Hospital. Throughout his career, he recognized the importance of science while constantly practicing quality and compassionate patient care. In his memory, Dr. Carol Catton has established this important lectureship. Given that all that AIM stands for, we strongly feel that this year's Drapkin awardee exemplifies the aims of this honor. Dr. Dua received her medical degree from the Maulana Azad Medical College in India. She went on to complete her internal medicine training at Good Samaritan Hospital of Johns Hopkins University, where she also served as chief resident. Subsequently, Dr. Dua completed a pulmonary and critical care fellowship at the UNC at Chapel Hill. Dr. Dua currently serves as the program director of the Pulmonary and Critical Care Fellowship here at Mount Sinai. Dr. Dua is also the medical director of the Fellows Ambulatory Care Clinic and serves as an associate professor of medicine. More recently, Dr. Dua was named the Department of Medicine Wellness Director for our house staff and serves as the director of GMU Wellness Champions. Dr. Dua's medical education interests include trainee wellness as well as faculty development and teaching in resource-poor settings. She additionally serves on the education and trainee committees of multiple organizations such as the Association of Pulmonary and Critical Care Program Directors and ATS. Please join me in giving a warm welcome to this year's Arnold Drapkin Award winner, Dr. Sakshi Dua. We also have this plaque.
The new job title.
Move this way.
Slide.
Go on the other side of the podium.
Yes, there you go. There you go. There you go. Yeah. Oop. No expense spared on photography.
Thank you so much. This is quite an honor. And the reason why I chose to speak of my medical education mission to Ethiopia that I go to every year is really in the hope that you're going to leave from here a little more inspired than when you walked in. So let's dive in. I have no disclosures that are relevant. So for the purpose of the next 30-40 minutes, I'm going to walk you through the background of healthcare in Ethiopia. And this is going to provide you the context in which this fellowship training program was created, and I'll share the structure and the model. And then I'm going to share my biggest challenges of teaching in a resource-poor setting, and then how did I navigate those challenges by applying the adult learning theory, and then we're going to close with some final reflections. So starting off, Ethiopia is located in the eastern horn of Africa, with a population of 105 million. It is the second most populous country in Africa. And as you can see from this map, it is not surrounded by the most stable of neighbors. It is a very poor country. In fact, World Bank data states that it has the lowest GDP per capita in the world, and 80% of its population actually lives in rural areas where they live as farmers on subsistence farming. Only a third have any piped water supply, and less than a quarter have any electricity. And more than 50% of Ethiopians do not have any access to education. A third live below the poverty line, which is $1 a day for Ethiopia. And it is a very high burden country for respiratory diseases. For example, TB incidence is about 200 cases per 100,000 population. And although no statistics are available, there is a high prevalence of asthma, COPD, and lung cancer. And of course, there's a lot of indoor air pollution because of biomass fuel that is used for cooking and heating. It has a very underfunded healthcare sector. In fact, less than 5% of GDP is utilized towards healthcare. And when this program was initiated, there were no respiratory physicians trained in pulmonary medicine in the entire country. In fact, a majority of physicians are general practitioners, and there's minimal to none postgraduate training in Ethiopia. Having said that, the doctor to population ratio is extremely low, less than 1 doctor per 10,000 population. And I give you comparative stats here where the surrounding countries fare a little bit better. India and China fare a lot better. And then we're very spoiled here in the USA. We have 25 physicians per 10,000 population. And of course, the Swiss get the chocolate after all, so they have 40. So with that as your context and background, I will talk to you a little bit about what the East Africa Training Initiative was. This was started in January 2011. It's a collaborative effort between the Addis Ababa University School of Medicine and the Federal Health Ministry of Ethiopia in collaboration with the World Lung Foundation and the Swiss Lung Foundation. The World Lung Foundation and Swiss Lung Foundation assumed responsibility of creating the fellowship curriculum and recruiting volunteer faculty to provide on-site training, whereas the Addis Ababa University and the Health Ministry assumed responsibility of recruiting the fellows and paying their salaries. So this pilot program was started at the Black Lion Hospital. This is the main teaching hospital of the Addis Ababa University School of Medicine. And as you can see, very under-resourced. And it is the largest public hospital for the country, has about 600 beds. So just a little bit about the structure of the fellowship. It was modeled after the European model of fellowship. It's a 2-year fellowship training program. The first year is spent developing clinical and procedural skills, and the second year is devoted to a little bit more research method training added on in participation with the American Thoracic Society's MECOR program. So MECOR is Methods in Epidemiology, Clinical and Operational Research. So this is where yours truly comes in. I was recruited as a faculty volunteer to travel to Addis. A schedule of 2 to 4 weeks was provided with several rotating faculty, mostly from Brown University and Columbia University and NYU. And we adopted customary roles, things that we are used to here, including leading bedside rounds in the wards, running medical ICU rounds, giving didactics, precepting fellows clinic, supervising fellows, and then evaluating trainees. So let me walk you through the 2-year fellowship curriculum that was started. First of all, these services did not exist prior to us going in there. So a pulmonary consult service was started. Medical ICU rounds were initiated. A chest clinic was started, and we introduced bronchoscopy and pulmonary function testing for the first time. As you can imagine, the pulmonary curriculum involved topics such as pulmonary function testing, tuberculosis, lung cancer, asthma, COPD, pneumonia, interstitial lung disease, and pulmonary hypertension, to name a few. The critical care medicine topics included acute respiratory failure, septic shock, mechanical ventilation, arterial blood gas analysis, and ARDS. And then procedural skills were initiated for the first time, introduced bronchoscopy, even ultrasound, spirometry, and central line placement, utilizing donated equipment, of course. And then for research projects, the top 4 topics that were chosen based on the high prevalence were COPD, asthma, tuberculosis, and lung cancer. So this is where I share photos, and by the way, for this entire lecture, all the pictures that you're seeing were taken by me personally. So this is an example of pulmonary consult rounds that we're doing. This is the ER that I show here, and this is one of the patients that we're examining during rounds. An example of medical ICU rounds where the residents are getting ready to present their cases to me. A very bare bones chest clinic was initiated It was started as a half a day a week clinic, but then as the demand grew, it became twice a week clinic. And as you can see, there is a computer here. It does not work. And it was a mixed blessing because there was no Epic. As you see, the demand for chest clinic grew a lot. These are patients that are waiting patiently to be called in for their chest clinic appointment. And of course, we introduced bronchoscopy for the first time using donated equipment. And a procedure room was also initiated for procedures such as thoracentesis, pleural biopsy, etc., and using sonogram for the first time. And of course, the most important part of the day used to be didactics. I pre-prepared a ton of topics to take over with me there. And these were so impactful. These trainees were so hungry for knowledge that they would not want to limit themselves with only once a day didactics. So there were times when I was doing twice a day didactics, and the entire residency would shut down when Dr. Du was around because they would all want the residents to come in and listen in on the didactics. And so what have been the program achievements thus far? So we've so far graduated 13 total fellows. Research projects that they did in their second year of training have been presented at international meetings. And for the first time, an Ethiopian Thoracic Society has been established. And here I share a photo of the first 2 graduates of this program. They will look familiar to some of the faculty here who've been involved with the program. Notice one of them is really much older than I am. Okay, so based off of that, I wanted to share some of the challenges that I had in teaching in a resource-poor setting. So for me, the biggest one was the lack of infrastructure, equipment, and supplies. It's one thing to give a lecture on arterial blood gas analysis, but if you don't have an ABG machine that can actually check arterial blood gas, it's all very theoretical knowledge. Of course, I could train pulmonary critical care physicians, but if they don't have the support of trained nurses and bronchoscopy technicians or pulmonary lab technicians, the training is little limiting. And also they did not have the support of any other specialists, such as radiologists and pathologists. Sometimes training attitude was very fatalistic because this is the way things are, there's nothing more we can do, and that's where that would be a full stop. And also remember, these are physicians who are taking care of patients in this way for several decades, and so they were sometimes uncomfortable as being change agents. They didn't want to seem to be shown as fighting the system that was already in place. Of course, there were cultural factors. This is a very paternalistic society, and the medical system is very hierarchical. And of course, there were language barriers because I couldn't directly converse with the patients, only with the trainees. In fact, there would be times when patients or their families would come up to me and start talking to me in Amharic. And I would get so flattered because I figured that, oh, way to blend in, Sakshi Dua, way to blend in. Of course, the lack of technology was a problem, and especially not having internet access was a huge problem because even in training and learning, immediately being able to look up stuff is very important, and not having a Wi-Fi really hurt. And of course, there were personal safety concerns, including, is the food safe to eat? Am I being exposed to tuberculosis everywhere, especially MDR TB? And of course, there were years when I was like, maybe I shouldn't go because the political climate was not very stable. There was a lot of tribal tension 2 years ago, and I almost didn't go. But thankfully, Addis was still quite safe as a city. So here I share pictures of the low infrastructure. There was no running water on the Department of Medicine floor at the Black Lion Hospital. And of course, when we lost power, I had to revert to the old chalk style of giving didactics. And yes, this constitutes a MICU bed. This is a medical ICU bed. All it takes is a monitor and giant cylinders of oxygen to make it so. And of course, this equipment was really old. And here I share photos of the chest tube drainage system, as you see here, again, old and broken. And the lack of central line kits, the result of which was giving peripheral dopamine, which we all know how that ends up sometimes. And of course, this is especially for Dr. Linda Rogers because I got so excited when I found an inhaler to treat patients' asthma and COPD. Of course, there was no trained radiologist on site, so I was it for most days for the trainees. And of course, because CT scan is such a new technology for them, the trainees were very, very, very hungry for knowledge on CT scan training. And most of the days, we had pleural fluid cytology that would just come back as carcinoma. Everybody's pleural fluid cytology was a carcinoma. So there was no trained pathologist who could really give us help in diagnosing our patients. So most days, I was it. And of course, I told you about the personal safety concerns. I would get really intimidated when I saw paramilitary personnel with big guns walking around the hospital all the time. As you see, my trainees are completely unfazed. Okay, so now that I shared challenges regarding teaching in this resource-poor setting, how did I navigate these challenges? Well, coming back to the old adult learning principles. Now, most of you who are in med ed, this stuff is very familiar to you, but for those who are not in medical education, please bear with me because you're gonna walk out of here learning something new. So as you guys know or may not know, adult learning principles are very different from the way children learn. For adults, they really need to know why. Why are we learning something? Also, adults are more internally motivated, what's in it for me, compared to children who may have some external motivations such as parental pressure or punishment from parents. The adults are ready to learn only when they have a context of relevance in what they're being taught, and there are also more practical applications of learning, and this is why problem-based learning is a really good way to teach adults. Also remember that adults come with a past experience, and so they will analyze and rationalize every information that's presented to them. Adults are definitely more self-directed in their learning, so will take charge. And then the orientation of learning of adults is really more task-oriented, so learning by doing is more important for them. So how did I apply this old adult learning theory towards my situation? Well, I dug deeper into the experiential learning cycle. You know, the experience of learning for adults is the cyclical learning of having a concrete experience, which would be doing or having an experience, and then a period of reflective observation, which is where they review and reflect on the experience, followed by abstract conceptualization, so learning from that experience, and then active experimentation, which would be doing what they just learned. So just to give you a very simple example, this is the concrete experience of one of my trainees learning to do a bronchoscopy. This is reflective observation when my trainee is observing me demonstrate how to do a bronchoscopy and how to negotiate it. This is the trainee utilizing that new information that they've learned in reperforming the bronchoscopy. So this is abstract conceptualization. And finally, active experimentation where the trainee is able to successfully perform difficult bronchoscopy. So how does this apply to us all? Well, for me, it made my expression of the adult learning theory just more explicit than it is here in the US, and really enriched my focus on teaching, and one could argue faculty development upon returning back here. And for you to consider would be, how do you apply adult learning theory and the experiential learning cycle in your day-to-day teaching? So, final reflections from this program. My final tips for teaching in a resource-poor setting would be, really understand the context in which you're teaching. Remember that the teaching has to be very practical. So I was almost existing in a parallel universe where what Sakshi Dua would do in the United States of America is not what Sakshi Dua would do in Ethiopia. I had to be very flexible, so I had to adapt to the workflow of the day, and very opportunistic in teaching, seizing every teaching moment to teach. Of course, humility goes a long way, and I was constantly soliciting feedback, and I argue every year that I go back, my experience and their experience of me gets better and better. And of course, the moment I got there, I wanted to identify local trainers and build local capacity for sustainability. And of course, it really, really reminded me of my gratitude for everything that we have here that we take for granted. And here, of course, I show a photo of the lady who was on staff at the Department of Medicine who would serve us coffee every day. And of course, as everybody knows me, I only go back for the macchiatos every year. Behind here, I was reading the Blue Journal that had an ad for the National Jewish Respiratory Institute. So in my final reflections, I would say this program, this medical education mission, has really provided me an opportunity to find my purpose, what I love doing, what the world needs, what I'm good at. I take that back. I don't actually get paid for doing this, but this is why I have Dr. Powell. So with that, I would like to conclude this little award lecture. I would like to acknowledge Dr. Neil Schluger at Columbia University and Dr. Charles Sherman at Brown University, who recruited me to the program, and my division chief, Dr. Powell, for allowing me to go year after year for 2 weeks. I would like to thank my Ethiopian trainees and all the faculty volunteers, and if anybody's looking to donate, that's where the website is, vitalstrategies.org. Happy to take questions.
First of all, congratulations. When I get home tonight, I'm going to tell my wife about your lecture. She's not a physician, and she's 75 years old, but when she was 20, She went to Ethiopia for 6 months. And you can imagine the setting in the days of John F. Kennedy, even before your arrival in Ethiopia. So she'd love to speak with you. My question has to do with geriatrics, the area I work in. There must be very few older people as patients in Ethiopia. How would a physician from Ethiopia come to America and apply for a job in geriatrics, and how would they begin to work with old patients in America?
Very good question. So the question was related around geriatrics. How would an Ethiopian physician who is being trained in a setting where there are not that very many old people function in the US? So yes, right on. The life expectancy in Ethiopia is an average of 60 years. Women fare a little bit better at 63, but men have an average mean life expectancy of 58 years. And so yes, there are not very many old people in Ethiopia, and Ethiopian trainees don't really get trained in geriatric medicine. I would say this would have to be relearned by Ethiopian trainees when they come to the US system. I would like to tell you, as part of this training program, these fellows that are being trained by this program do come to the US for a 4-week observership. They stay 2 weeks at Columbia, they come for a day here at Mount Sinai where I host them, and then they go to Brown University for 2 weeks. This is a 4-week observership in which they do get exposed to our US system of working. And of course, distance learning, I can't tell you how important it is to have that technology. Again, a long distance learning has a long way to go, but it plays a big role when you are in resource poor settings, because if you can just identify areas of improvement and just video conference them in or Skype them in, that would go a long way as well. Dr. Powell.
Yes, that was great. Thanks for giving back to us. So you've been in this program for a while, really since its inception, I would say, right?
Yes.
So what do you think has been the impact of the program? Before this program, there were no pulmonary trainees. There was no pulmonary program, but there was a lot of lung disease.
Yeah.
So now with having pulmonary fellows and a program, what has been the impact on health in Ethiopia, do you think?
This is a super question. So the question is, what is the impact of this program on Ethiopia, other than the fact that we just had trainees? So 13 trained physicians are not going to be able to make a huge impact on the public level of a 105 million population. However, having said that, these trainees are being trained to now be faculty of the Division of Pulmonary Critical Care Medicine to scale up this program so that we're training the trainers at the moment. So 5 of the graduates have stayed on in the Addis Ababa University School of Medicine as faculty to further recruit further trainees. So that's number one. The most important, I would say, is because of this program, for the first time, public health issues were raised and quality issues were raised. So before we got in there, there was essentially no infection control, masks, gloves, etc. So for MDR TB, for example, so for the first time, guidelines, checklists, protocols were introduced for the medical ICU, for example, or for the ER. So this is where we have a public health aspect of this training program, where for the first time we had statements issued, protocols. This is all in collaboration with the leadership at the university level and also the federal health ministry at that level. That's number 2. And number 3, the most important, is QI initiatives. So quality assurance for the first time entered this realm in Ethiopia. So yes, dispersing this knowledge to further trainees, recruiting the current trainees as faculty, and also giving them more administrative and leadership training, which is the next step up of this, and also the public health concerns, including initiating an Ethiopian Thoracic Society, something that did not exist for CME of general practitioners. You can't train everybody up, but if general practitioners had a chance to get continuing medical education in respiratory diseases, that would have the wider effect.
Are there similar initiatives in other specialties?
Yeah, very interesting. So when we entered in January 2013 in this program, the only other specialists that existed with a training program at this school were GI. So that's whose room we borrowed for our bronchoscopy. Yes.
So you showed this asthma inhaler, which for me, immediately I thought about the pre-approval process we have to go through. So my question is, are there resources when you start people on these long longitudinal medication? Is this sustainable? What's the mechanism to keep these people?
Unfortunately, none. So this is what the problem with poverty is, that if you don't have access to the basic physiological needs that are not being met, that Maslow's theory of human motivation, with the needs of education being on the highest of self-actualization. So yes, we had an issue with, yes, we know theoretically what we can do to treat somebody, but access to medications is limited because these are poor farmers who have to deal with treating themselves and buying their medications themselves. There are a lot of chemists there that provide very low-cost medicine. And of course, antiretrovirals and anti-tuberculosis medications are all free of cost. And they're, generally speaking, because of India and China pharmaceuticals in there is a lot of low-cost medicine that is available. This was one of the VIP patients who actually had a Symbicort inhaler.
There's VIP patients everywhere.
Yes. Yes, Peter.
Great talk, thank you. So I saw that you guys were doing quite a good number of bronchoscopies, and you mentioned how prevalent TB was. I'm just interested in knowing how you guys went about sanitizing the scopes in between patients.
The same solutions. So the solutions were also donated. The way we clean the scopes here, we were using solutions to clean the scopes in between patients. Yes. Actually, since you brought that up, I wanted to share like a couple of photos of tuberculosis in every imaginable way that you can think of. TB everywhere, in every form imaginable. Yes. So actually, I learned a lot about tuberculosis being there. Yeah.
Thank you very much for an outstanding talk. Thank you.